Okay, so we're open for discussion. Questions for any of our speakers this morning?
Can I start asking? Sorry, as you showed this very nice registry from UK and Denmark, but to my understanding, those registries are all from 1 year age on. How do you manage in terms of registry, molecular autopsy and things like that, SIDS cases or intrauterine fetal demesis?
Good question. As I say, the SIDS deaths in the UK are all handled by paediatric pathologists, and they carry out a very thorough autopsy, including taking of molecular material. Now, Elijah, you may know more about it than I do, because I'm not a paediatric pathologist, so I would not be dealing with the sudden infant deaths. So you may, because Elijah's doing some collaborative work on that.
There is the monitoring of childhood and infant deaths by the safeguarding panels. I can't remember the official name of them. Somebody may be able to remind me. And these are all monitored and surveyed regularly, and unexpected deaths are reviewed as part of that. Regular databasing and registry of the unexplained deaths isn't really happening in a systematic way otherwise. It's dependent on specific, and there have been some large cohort studies that have undergone the Avon study, a big collection up in Edinburgh as well, in the MRC in Edinburgh, and we've managed to pull together these groups into a collaboration to look around. We have about 800 SIDS cases with DNA and very accurate clinical pathological assessment. And we're trying to pull that together into a research study. But as far as the regular recording of these deaths, there isn't an official database system at this time. I mean, this is something we're trying to encourage in sudden death in general through the existing NHS facilities. That's the NICOR system and the CCAD database, the cardiac databases. But we're actually starting off more at the adult end at this stage, and with Mary's national SADS database. But we haven't tried to go into the below the 1 year age group as yet.
We should, with our paediatric colleagues, try and establish the question of our cardiac cases. I think it would be an exciting project to do. To my knowledge, there's no national paediatric forum for it at the moment.
And in Denmark, we will handle them the same way as all sudden unexpected death. So if in a case of a SIDS, that would be after the autopsy, then we would want to have the parents referred to us, and then we can start the family evaluation. We have just started doing that on the SIDS cases. It's true that we are focused from 1 and above. I think SIDS is somewhat different disease, maybe, at least in some aspects of it, but I think now we are beginning to dealing it the same way. Regarding the intrauterine, we have no follow-up on that, and I think you're leading the way into novel territory there, and I think we should follow.
And sorry, if I can make another question. While in all your registry, you of course collect the family history for sudden cardiac death, at least that is a question. Do you collect also, can you have an idea of how is the incidence of SIDS in the families in which there was a sudden cardiac death later in life? Do you have an idea of that data?
Well, actually, in our database, we've got, I think it's 1%. Sorry, 1% of cases, we think, in our adult that SIDS, but obviously you will find that there's been an infant. We now specifically ask, whereas previously, retrospectively, the question wasn't asked. It's only the more recent data we've got the sudden infant death incidence.
Thank you very much. Okay, can we just move on to the next question? Perhaps we can.
Thank you to the speakers. I enjoyed your presentations. Mary, I'd like you to stay up there because this is going to be directed at you as well. I'm I'm very impressed with the Danish collaboration and how you gather so much tremendous information around the country in such a collaborative way. And it's great news, Mary, that the chief pathologist is now encouraging pathologists to send the tissue to yourselves at George's, because I do think we need a national leading centre to collaborate and coordinate things in the UK, because it's a continued frustration to us that we don't really understand what is going on in our own areas, because we don't have day-to-day communications with pathology like you guys have at George's. Do you see that we're going to have something a little more coordinated? Do you think that's an aspiration, not only within pathology but within the clinical side?
Well, I think it's up to the clinicians to answer that, but we are now with the Association of Inherited Cardiac Diseases. Give it a plug there, Elijah.
I'm supposed to be distributing this, not using it. At the Association for Inherited Cardiac Conditions is very much behind all national efforts to improve ascertainment of sudden cardiac death in the young and to ascertain cardiac genetic disorders. And there are two initiatives from that point of view. One is the initiative to support Mary's SADS database and to try and coordinate communication between clinical centres and clinical genetics centres and Mary's database to improve ascertainment of sudden death cases, and then also between the coroner's pathologists and any specialist pathologists around the country to input their data, so we have a complete pathological record. And in those areas where there is not a relationship between a clinical genetics centre, regional lab that can immediately store splenic tissue, that we provide the service to be able to rescue that tissue before it's lost to the family and also potentially lost to research. The other aspect of that work is to try and develop the databasing of the families and of individuals, and at least to be able to assess the quality of the service that we provide as clinical providers, but also in the end to base research upon that and to be able to link in to the SADS databases and provide something meaningful. In the end, we would like this to be part of the CCAD databases, but that's us. We have to show that it's going to work, that it's going to deliver audit and clinical governance as a first step, and then we can be taken on from that point of view. In an era of austerity, we have to make a very good case, so it's really going to be engagement with many of you in the audience, successful engagement in achieving those objectives.
Okay, I think we've got a question over here. One on the left and then there's one on the right.
Is that for me?
Yes.
You talk about molecular autopsy as though it's a single test. I don't think any of us have decided really what we should be actually looking for in the molecular autopsy. And I think one of the most important things that whatever we do look at for, we actually completely document, because it's not a single test. And with the generation of next generation sequencing, every lab is doing something slightly different. And therefore, I don't know how we're going to record what everybody is actually doing, because it's a very variable test. Have you thought about keeping everything, Mary, on a database with your...
Yes, I'm putting in the genetic follow-up, which is going to be very important. Any reports we get from any centre, from you, from other centres on this, and to collaborate with them, and with the clinical follow-up as well in the family, the phenotype, genotype.
If I can add something as well, you raised a very important issue, and because of sure we all know that there are genes responsible, for instance, for channelopathies that are the so-called major genes in which the data are more solid, supporting the relationship from the disease and the mutations. While, for instance, with these next generation panels, usually you include a lot of minor genes, but the data supporting the pathogeneity usually of the variants of the minor genes is less solid. So I would be very careful in extrapolating a diagnosis based on a diagnosis done only minor gene. But even in the major genes, that are mutations that we are sure that are really causing the disease, while there are a number of variants that are the so-called variants of uncertain significance, in which we are not sure what they are really doing. So at the end, it's very important to correlate the mutation with the clinic in the family members. That is my view, at least.
But it's also got to collect it all so that we can actually see. We need to collect all that data so that we can actually compare it with other cases. So we're not going to use it, but we do need to collect it for research.
Yeah, that is essential. That is absolutely essential.
My question is quite similar to the previous one. So is there a panel of genes that you would suggest to use in these cases? Which genes to screen? Because there are a lot of genes. So.
If you want to do a diagnostic, so if you don't want to work in a research setting, I would suggest to follow the indications that are given for the diagnostic screening in patients with those diseases. So only the major genes associated with generalopathies. But of course, we need to improve significantly the knowledges in this field. So once is the diagnostic, but I think that we really need to accumulate data only on what is less known to try to understand things better.
May I add something here, Elijah? So I'd just like to emphasize that sudden death without any other clinical information is a very weak phenotype to start these studies, because you don't have any clue whether anything you find is related to what happened. And you are referring to the genes that are in the diagnostic panels. I don't agree. For example, in the long QT syndrome, there are 14 genes, and only 3 of them, maybe only 2, are really diagnostic. If you find a mutation in the transmembrane domains of the potassium channels, then you know that there is something. But the sodium channel is very dangerous already. Big part of the sodium channel, everything you find has a predictive value of almost 0, whether that is related to the disease. So I agree that you should sample everything, you should store everything, but communicating with the patients is a very difficult thing.
At the back.
May I ask about reimbursement of the mandatory autopsy, Jacob? I assume that's part of the discussion with the politicians?
Yes.
Who's going to pay for it?
Yes. So we went to the parliament, and they say, you know, it all depends on how your healthcare system is built. But in Denmark, we have like cities, and then we have something which a regional council, and then we have the country. So first we went to the parliament, which is the country, and they said, oh yeah, we think it's a great idea. We even went to the press and say, yeah, we're going to do this. But then they say, but you know, we are not the one to decide. And so now we have been in that process for 3 years. But what I hear is we are having a meeting here in December where it may be decided. But the cost, of course, is important. But I think Elijah showed that this kind of workup in the family, when you have so many that will have a disease, I think it's really something that pays off. And that's really what we are trying to say. It pays off to do this. We will prevent sudden cardiac death in the future in these families.
Well, this is a question to Dr. Felft. Why do you include in your classification the pulmonary embolism as a cause of non-cardiac death? Because pulmonary embolism, in other classifications, including...
It's a very good question, and a question we always give. So the first time we wrote up the paper, we included those, and then the reviewer said, yeah, we really like your papers, but you need to take the pulmonary embolism out. It's non-cardiac.
Yeah,
so that's...
We take it out if we don't include pulmonary embolism.
So I think it's a question of nomenclature. That's all.
Okay.
In the back, please.
Thank you, Arthur. I just wanted to reinforce the idea of caution with genetic results. If you don't have somebody who's living and affected to test out your mutation, it can be very, very challenging. And I think it raises a lot of expectations within the family that you do have a useful variant or a useful result that can be used for screening. And whilst entirely agreeing with Tessa about the need to collate this information, to carry out testing for research purposes, I think the value of it in terms of family screening at the moment is quite limited, and it's important to be mindful of that and not to have families who are requesting this testing where really we can't alter their management on the basis of negative results.
Another one over here on the left. Yeah, just there.
Sure. Yeah. So I have a question to Mary Shepherd and the whole panel. Wolff-Parkinson-White syndrome or accessory pathways. This is an issue, I think, that is not looked at very carefully. We know that data from the Olmsted County 20 years ago showed there's a nice bimodal distribution in diagnosing an accessory pathway. So if you look at babies, you'll see a lot more accessory pathways than if you look at teenagers. And if you look at children who have accessory pathways, and you look at those same children 10 years later, less of them have accessory pathway antegrade conducting, so delta waves. So is there not a significant group of children or babies that are dying suddenly of basically accessory pathway mediated tachycardia that we're just not diagnosing? We know from animal preparations that the AV conduction system undergoes a lot of changes, even postnatally. And so you're left with an AV node and a His-Purkinje system, but there are other connections that have to involute to develop normally. So any comments would be nice.
You were asking, I think, the $600 million question, because at autopsy, I look at the conduction system, but I don't serially section it. And I'll be utterly truthful, I don't think there's anybody in the world who knows the normal conduction tissue, anatomically I'm speaking about. Because when I see it, there's such a wide variation in the shape, size, and bundles that come off the AV node, that me making a diagnosis of accessory pathways, never mind a pediatric pathologist looking at pediatric cases, we know nothing about it from an anatomical point of view. Yes, there was previous older studies where there was overinterpretation of what we consider now normal findings. So we don't, in Wolff-Parkinson-White, if there's a diagnosis made in a child or an adult, I accept it as the cause of death, but I will not serially section the conduction tissue because it's about 3,000 sections. And I won't be able to point out to you exactly, and also the whole AV junction will need to be serially sectioned. So you're talking about 5,000 sections. That would take me a whole year to look at one case. And even then I wouldn't be certain, is that the actual accessory, little tiny muscle bundle? So it's a huge challenge. Ye electrophysiologists know more about it than I do, but I accept what I'm told. If it's Wolff-Parkinson-White or accessory, I will accept it as a cause of death when the heart is otherwise anatomically normal.
Thank you.
May I ask Mary another question on the hypertrophic cardiomyopathy and the differential diagnosis with idiopathic LVH? So you made the clear statement that patchy myocardial disarray is the main discriminator between...
For me as a pathologist,
Yeah.
it has to be disarray.
But is your autopsy, is the resolution of your autopsy enough to pick up patchy myocardial disarray?
There is always patchy myocardial in every normal heart.
Yeah.
Pathologists can overestimate, particularly at the septal junctions, posterior and anterior. So you can overinterpret disarray. For me to have disarray, I need to see it in the sections of the interventricular septum and the free wall of the left ventricle, in nearly every section. I have to see disarray. It can vary, and I have to do a lot of sampling. And as I say, idiopathic is where I see absolutely no disarray. Sometimes you are absolute, it can be subtle disarray. I leave it open in those cases as to whether it's hokum and rely on the cardiologist with family follow-up with possible genetic analysis to tell me.
And what then would you speculate is the cause of death in idiopathic LVH?
That's something we're looking into. Whether it's actual hokum in disguise, we don't know. We're literally starting to look families genetic-wise at those, because nobody has done the screening with the usual hokum mutations in these cases. We're only prospectively doing it.
Well, what is the arrhythmogenic substrate in idiopathic LVH without disarray?
A lot of them have fibrosis.
Okay.
A majority will have increased fibrosis in the left ventricle without disarray.
And some of the families in that Michael Papadakis study that we did with Mary had ion channel diseases underlying it as well, as a very small amount of cardiomyopathy in that one limited study.
Mm-hmm.
We've heard a lot about post-mortem studies, but of course there's a much larger, increasingly large group of cardiac arrest survivors. Are they relatively neglected when it comes to studies like this? And what do the available studies tell us about causes of death there? To anyone on panel?
Cardiac arrest.
Yes. So in Denmark, we treat them in a similar fashion. So if you're below 50, then we will also do workup on the patient, which is normally done within the hospital before being discharged. And then we'll also evaluate the family as well. At least in our institution, it seems to us that we don't find a cause very often. I think we have not estimated this, but I would think idiopathic VF is 50% among the young. Yeah.
Can I ask a question to the panel in general, actually? You mentioned, Leah, the exome variant server data. Do you think that all this increase in information is actually going to cause a problem? Because, as you say, there's a number of studies now that have shown, particularly for cardiomyopathy genes, that there are variants in the general population. Is this going to be a problem for clinical diagnostics? And should it mean that we actually spend more time looking at other variants in patients that have got a primary mutation identified?
I think that these databases, and then there is one pretty new from the Broad Institute that has even a larger number of cases, are really a precious resource to let understand things much better, because my opinion is that in the past, above all for some kind of genes that we know that can be quite polymorphic, a number of false molecular diagnoses have been made simply because that variant was not present in 100 controls, and that was a way of behaving that was acceptable many times ago, many years ago, but clearly now is not anymore acceptable. Clearly, finding a variant in the general population does not mean that this variant is not doing anything at all. Of course, if you find it in 30% of the cases, it's very unlikely. Of course, you have to consider, but there are no clear guidelines, which is the prevalence of the disease you are dealing with, which is the severity of the disease. For instance, with the calmodulin mutations that we identify causing, in the case we follow, 17 cardiac arrests in the first 2 years of life, we couldn't expect an adult individual surviving with that mutation. But that is not the case for many diseases that have a lower penetrance and that can manifest later in life.
I mean, you could also argue that these population databases, you don't know what age they've been taken at, you don't know whether they will suffer a cardiac arrest later on. So almost seeing it perhaps isn't enough.
I think that the scientific community should make two major efforts if you want to really try to use sorry for my voice, to use data better. From one side, of course, it would be better that patients undergoing exome, and so patients in which these exome data would be available to have some information, also clinical information, to be added in the database. And I feel that the people working in our field instead should create a serious common database of variants identified in subjects with arrhythmogenic diseases, both channelopathies and cardiomyopathies, in which we really know that those are really disease-causing, because there are a number of compendium, a number of databases, some old papers in which variants are mentioned as disease-causing, but now we that are in the field know that are not really disease-causing. But people working, for instance, with exome and have to deal with these incidental findings, they would look at this compendium and report that as a disease-causing variant. So I think that the scientific community should make an effort to try to characterize better the variants identified so far.
Can I add a comment? I think this also points to that it's, when we sit with these cases, it's very important that we are multidisciplinary, that we also get a very good judgmental on whether the variant should be followed or not followed and how to counsel the family. I think what you're saying is we really have to be careful at this time point, but also we should not be too scared. And I think the phenotypical presentation of the family is key to this, as well as also looking at the individual mutation.
The major problem is the starting point, because if you start with a strong phenotype and you have the judge a variant, I think is different because you have the family, you have the strong phenotype, and you have a person that is familiar with this data that can deal with it. The real problem that is coming up now is the question of incidental findings in patients screened through exome for other reasons, and in which variants in our genes are identified. What should we do? Should we send all these cases to a cardiologist, even if are minor genes? I don't know. That is, I think, something that we should face.
And I think also it may point to when should we initiate the genetic screening? Should it be before they have been seen by Elijah and we found a phenotype in the family? Or after, because maybe we will, if we have a good phenotype in the family, maybe it will be helpful in deciding which genes to look at. Exactly the question of the phenotype that Vilde set out and which genes to look at. I think there may be different ways to do this.
Okay, there's one more question in the back, please.
Okay, thank you very much. It's very interesting, but it's very difficult to see to know we are between research and diagnostic settings. And my question was, at which moment do you reach the family members to communicate or to propose cardiac examination or genetic counseling? At what moment do you have a contact, and do you have a systematic contact with the families?
I think that's a very good question that we don't. So I think the question was, when do you reach out to the family and say, we should come in? In Denmark, what we do is everybody dying sudden, unexpected at the age of below 50. That's our cutoff. I know it's different here in the UK. You will go higher, 65, right?
Yes, because half my SADs are over the age of 35. I just say it. Yes. In the database, I've found that half my SADs are over the age of 35, and they've no coronary artery disease. Right, I'm quite precise about that. So we consider up to 65, if it's morphologically normal heart, should be screened.
But the correct thing is that the GP needs to be prompted by the coroner and by the coroner's pathologist. The GP may not understand or know the implications to the family and may not even link the death to the family if they've been notified of the death. They will be notified clearly, but any other recommendations are going to have to come from the coroner. So education of coroners and education of pathologists has been a really important thing, and Mary and other colleagues have been doing that for a long time now, and I think we have had some success.
Yes, we always in our report state family should be sent for screening as soon as possible. And in addition, the chief coroner here has said that coroners now have a duty of care to inform families if such a diagnosis is made.
Just one. In Denmark, what we will do is if there's a sudden unexpected death cases, the pathologist will write the police and say, if you do nothing, then they will be contacted by the cardiologist. So that means it will come in actively without, so we will just get the numbers and then we will contact the family.
Is that a new system, Jake?
Yeah, that's a number.
Or in other words, you're informed for every sudden death.
Yeah.
So bypassing primary care.
Last question.
One last question, maybe. Jacob, what is the reason for the differences in incidence or prevalence between different countries? So that ranges from 1.0% to 2.6%, whereas these countries are not that much different, I would say.
I don't know. I think it may have to do how you assess it, so the methodology. I think also what you could say we have included non-autopsied in some of ours. I'm not quite sure.
Okay, if that's it, I'd just like to thank the speakers again.